This episode of the GeriPal podcast is CME eligible.
To claim credit, please go to the CME tab on GeriPal.org.
We'd like to take a moment to thank new donors who've supported the GeriPal podcast for more than $100, including
Lori Elizabeth Hancock, Karen and Robert Ayers, Anna Lynch, Deborah and Jeffrey Larson, Krista Mossack, Ed Martin, and Stuart Oserman.
On to the show. Welcome to the GeriPal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome back Jennifer Temel, who's a thoracic oncologist at Massachusetts General Hospital in Boston. Jennifer, welcome back to the GeriPal podcast.
Thanks.
And we're delighted to welcome Chris Jones, who's a palliative care doc at Duke in North Carolina. Chris, welcome to the GeriPal podcast.
Thank you.
And we're delighted to welcome Pallavi Kumar, who is a palliative care doc and oncologist at the University of Pennsylvania. Pallavi, welcome to GeriPal.
Thank you.
So we're going to be talking about a model of outpatient palliative care, a stepped model for palliative care. But before we jump into that topic, Jennifer, do you have a song request for Alex?
I do have a song request for Alex. I have requested Galileo by the Indigo Girls. And the reason I requested it is because it is one of the two most famous Indigo Girls song, with the other being Closer to Fine. And most people think Closer to Fine is better, but they are wrong. Galileo is better.
Alex, did you do Closer to Fine already? I feel like we've done that one.
Probably. I think I did. I was in an Indigo Girls cover band in college at the University of Michigan. Saw them play a couple times. Actually got a pick from one of them. I think it was Emily. At some point, I carried around my wallet for years until it fell out. And then we got in, our band strangely got in, we played like a talent show, and then we got invited to play at the Elks, or was it the Masons? I think it was the Masons Lodge. And boy, did they not know what to make of us. So this is a fun song. Thank you for requesting it. It's taken me back quite a few years. Here we go. Galileo's head was on the block. Crime was looking up the truth. And as the bombshells of my daily fears explode, I try to trace them to my youth. And then you had to bring up reincarnation over a couple of beers the other night. Now I'm serving time for mistakes made by another in another lifetime. How long till my soul gets it right? Can any human being ever reach that kind of light? I call on the resting soul of Galileo, king of night vision, king of insight.
I have a trial that's going on that's showing that there's association between the length that Alex plays a song on a podcast intro and his enjoyment of that song.
That was a lot of fun. Thank you for taking me back.
That could have gone the whole 40 minutes. I think you just repeated that. We could have just listened.
So I'm really excited because I'm very eager to talk about this study. So there's a study published in JAMA just a couple months ago this year on stepped palliative care and a stepped model. And I wonder if we can, before we talk about like why is a stepped model important, can someone describe for me what a stepped model is?
I can take that on. So basically with a stepped care model, the goal is to sort of tailor care delivery to the patient's needs, while at the same time utilizing less clinician resources. So sort of how it works is that all patients will have access or encounters with the specialty trained clinician, a psychologist, a social worker, a palliative care clinician, but they'll sort of have infrequent contact, and they'll be closely monitored for the condition that the specialist is treating them for. And if that sort of low frequency contact sort of solves the problem, i.e. their depression gets better or their depression doesn't get worse, they stay with that low frequency contact. But if their depression, for example, worsens, then they step up to more frequent contact with, for example, the psychiatrist. So it's really trying to, again, solve two problems, be a more patient-centered approach by having the care tailored to what the patient needs, but also when there's limited resources like psychiatrists or palliative care clinicians, trying to sort of triage care to patients who need it most.
Yeah. And so let me get this straight. So I think you, Jennifer, probably have like the most cited, probably should be the most cited randomized controlled trial of palliative care in lung cancer patients that every palliative care article I've seen, whether or not it works, always includes. It was outpatient palliative care in lung cancer patients. I know there have been studies afterwards too. That was not a stepped model of care, right? What was that?
That's a great question. So when I started this research 20 years ago, I'm aging myself in, national radio, TV, whatever you want to call this. The prognosis of lung cancer was pretty uniform. So for example, everyone who was diagnosed with an advanced or metastatic lung cancer had a prognosis on the order of months. And so when we started this work, we sort of made up an interval, but the interval we made up was monthly encounters with palliative care because many patients didn't survive more than 4 or 6 months. Thank goodness, in the 20 years since then, lung cancer therapies have improved, and lung cancer is a cancer population where there's really varying prognosis based on cancer characteristics. So unfortunately, some people still do live 4, 6, 8 months, but there are subgroups of patients that have better responses to therapies and can live a year or 2 years, or in some cases, many years. And so that was really the impetus for our team thinking about, how do you take a population who has high palliative care needs, but has really varying palliative care and supportive care needs based on their treatment, their different prognosis, et cetera. And that's why we thought about applying a stepped care model to patients with advanced lung cancer.
I guess, Chris, from your perspective, like why, from a clinical perspective, why is it important to test this stepped care model versus implementing more what we know was evidence-based before all of this is?
Yeah, it's a really interesting thing because the 2010 article was solving the problem of, hey, send us patients. We promise we won't kill them, right? That was the initial. And now when I think about the clinic at Duke, when we're really running on all cylinders, we can get ourselves up to a 5, 6, 7 week wait for a new palliative care referral. And there's a mortality number of people who just can't make it to get to our clinic. So the problem of, hey, look at us, we promise we'll be helpful, we won't kill your patient, we've solved that problem. And we've solved it so well at some institutions that we now have this tremendous capacity problem. So that's the thing that I've really liked about the stepped model. Yeah, I've been the implementation arm of a couple of different studies, and I was in one where it was basically read this script and we're going to call it a palliative care intervention. I was like, oh, this is so hard to do. But this model,
did this happen in an ICU by any chance?
It might have. There might have been a GeriPal podcast or a Christian Sinclair article about this. Yes, but the idea in the positive here is that this model says you do palliative care, we'll keep an eye on the patients, and we'll let you know if they need more of you. Now, the rate limiting step in my mind is I don't have anybody to keep an eye on those patients in the clinic. So implementing stepped wedge would be hard. Now, we can talk later on about the different models of paying for care coordination. That would actually be a way to solve this problem. But I love this because of the capacity problem that we're suffering with.
Yeah. Any other thoughts, Pallavi?
I think it's also just patient-centered, right? So time is a precious resource. And, I don't know in your respective cities, but parking at our beautiful parking garage costs like $30 for the day. So saving people time and money and just the burden of being here for a visit that they may not actually need that day, I think is it's hard to put a value on that.
I love it. I don't think, a lot of doctors quite understand that sometimes patients feel like, I don't really need to see my doctor, but they're telling me to come, so I'm going to do this for them.
Yeah.
I have a question.
Go ahead, Alex.
Well, I have a lot of questions. But the first question is, when I first looked at this, I was like, wait, there's no usual care arm? There's no usual care arm. And then I got an invitation to speak at the Montreal Congrès de Palliative Care. And they want me to debate Vicki Jackson about this issue of we no longer should have usual care arms in palliative care trials. Like, have we moved beyond the point where it's ethical to have a usual care arm for patients with advanced lung cancer? I don't know who wants to take that one.
And Alex, when you're saying usual care, do you mean usual care not being palliative care, or like?
Yeah, or like palliative care if they get a consult for whatever reason, but not
like the PRN consult.
Like standardized, randomized to palliative care versus whatever they're doing before. If they get palliative care consult, they get one. If they don't, they don't.
First of all, Alex, I just want to compliment you on that really heroic effort on a French accent. Great job.
He loves doing a French accent, by the way.
Oh, really?
Don't get him started.
I mean, it wasn't great.
Don't. You started him.
Well,
For the rest of the podcast, he'll be doing a French accent.
Care palliative, not palliative.
Oh.
Yeah. I'm just putting it out there.
Thank you.
I would be shocked if anyone on this call said anything other than, of course, usual care cannot be the control arm. It's not ethical. We know that patients with serious cancer, like advanced lung cancer, need to be seeing palliative care. And I'm hinting at something we talked about before the recording started, but now that we're going with it, Alex had asked about non-inferiority and why that was the design. And the reason non-inferiority was the design, if we accept that frequent contact with palliative care is the standard of care, and we're trying to do something that entails less contact or less palliative care, that's the rationale for it being a non-inferiority design, because we have to make the argument it's no worse. It would have been hard to hypothesize that less contact with palliative care would have been better. So again, that's the rationale for non-inferiority, but I definitely do not think it is ethical to have non-palliative care, as Eric said, usual care, be a control arm when we're trying to improve on early longitudinal palliative care models.
And most of our listeners are like practicing clinicians, caring for older adults, people with serious illness. Can one of you explain, like in lay terms, what a non-inferiority trial is and how it differs from, I guess, we would say that most trials are superiority trials. Is this superior to that? But we don't actually put the word superior in there. Like, so what's a non-inferiority trial?
You guys want me to take this one?
Oh, desperately. Yes.
I feel like I want to make my statisticians proud. So it's basically, there are really, this is so unpleasant for a palliative care conversation, but sort of the three designs are superiority, non-inferiority, and equivalence. Probably at some point in the next couple of months, we'll talk about an equivalence palliative care trial. And that one's probably a little more easier to understand. So superiority, you're just saying one arm is statistically better than the other. For an equivalence trial, you basically have the sample size and the power to look at whether one is better or one is worse. Basically, that either one is better or worse. An equivalence trial is kind of in the middle. You don't need quite as much patients and quite as many patients and quite as much power as equivalence, but you need more patients and more power than superiority. So you're basically saying that the experimental arm is no better or no worse, that it is equivalent, that within a margin of sort of variation in your p-value, that the two arms are identical/similar.
And the difference in the design of those studies, is it mainly just the sample size, the power?
Yes. So the power has to be higher for a non-inferiority and then higher for an equivalence trial than it does for a superiority trial. And that increases the sample size. So for example, for a lot of palliative care studies looking at superiority, it's usually, say, 150 to 250 patients. This trial was obviously 450 patients. We have an equivalence trial, which will be published soon, that was 1,250 patients.
Oh, wow.
Wow. Oh, we are going to have you back.
I just misquoted my study. This study was 510 patients. Just ignore me, but you know what I mean.
Yeah.
You're creating like the all hat study now of palliative care. Once you get to 4 digits of patients, like we cannot aspire to 5 digits. It's just not a thing.
400 or 500 patients.
Well, can we talk about this study? Let's talk about what you did and who was included. Let's start off with who was actually included in this study, this 410-ish patients.
It was 510. I'm sorry.
510. Yeah, you're right. You said 500.
And now someone else should answer.
Pallavi?
Yeah.
Give us a little background.
Yeah. So adults with lung cancer. So that includes people with non-small cell lung cancer, small cell lung cancer, and mesothelioma being treated with non-curative intent. So I think that was one of the key eligibility criteria. They, English or Spanish speakers, and they had to be within, I'm going to get this wrong, within 8 weeks of diagnosis of advanced disease. Is that right, Jennifer?
Within 12 weeks.
Mm-hmm. So early-ish. Is that similar to your NEJM paper on early palliative care?
Yeah, so that is a great question. So in the New England Journal of Medicine paper, it was 8 weeks. In these more recent studies, we've expanded it to 12 weeks just because, when we do multi-site trials, there's definitely a learning curve enrolling patients in palliative care studies. And our research coordinator teams at multiple sites were saying 8 weeks is kind of tight to enroll patients or, have the time to approach and enroll patients. So for most of our multi-site trials, we've expanded the eligibility window to 12 weeks from 8.
So everybody was diagnosed with an advanced lung cancer sometime in the last 12 weeks. And then they were randomized to either this early stepped palliative care versus early palliative care, which is maybe not the usual care like Alex was saying, but it's the evidence-based care that we have from prior trials. Is that right?
We called it the early intensive palliative care.
Early intensive palliative care. Because the usual probably thing that happens is we wait for a palliative care consult. It's not case finding. And then when they come in, we'll see them. And there may be in more intensive palliative care, we see them every month. Does that sound about right, Chris?
Yeah, I think a month is pretty uncommon, at least in our clinic. Like, yeah, if I could hang the stars, if I was taking care of 25 people, I'd see them every day and they'd all feel great, right? But
or overwhelmed.
Yeah, well, or they'd have so much time toxicity, they'd drop out of cancer care. Those would be the two options. You decide if you'd want to see me every day. But no, that you named it, right? That 4 weeks, we probably do 6 to 8 weeks on our typical care patients. If have somebody who's hit a level spot, Jennifer mentioned earlier this idea of prognostication and, the people who are the PDL1 expressors. I learned more about people's dogs and about their grandkids because they were fine. There were a couple of people on my patient panel who were early intensive palliative care, and they did wonderfully for a long time.
Yeah.
Outside of this study, I wouldn't have seen them that often. So that's where that whole time toxicity question comes up.
So they were fine until they were not fine eventually.
Well, and some of them were fine until the study ended because we have some people in our clinic who are 4, 5, 6, 7 years stable metastatic non-small cell lung cancer, stable on immunotherapy. It's amazing.
Wow.
And back at that capacity question, right? If we're still getting people in, but instead of living 6 months, they're now living 6 years. That's a lot of appointments that we have to account for over time.
So let's talk about what was in the syringe in both groups. When we're thinking about a palliative care trial, I was thinking about, okay, what do they mean by palliative care? What was in this, stepwise or intensive palliative care group? What was the team made of? I can think of it like a spectrum. On one hand, in palliative care, it's like primary palliative care, people who've got a little bit of teaching. On the other hand, you got a full interprofessional team. You got palliative care, psychologists and social workers and pharmacists and NPs and physicians and nurses. The
chaplains.
Yeah, the full model that we love to talk about that actually rarely happens in the real world. Pallavi, what was the team made out of?
It's interesting. I think it actually varies a little bit even among our 3 sites in terms of the intensive arm. So at our cancer center, we have physicians, advanced practice providers. We do have access to palliative care social work in the outpatient setting, and we have a nurse. We don't have pastoral care actually readily available for our ambulatory patients. And so that's sort of our interprofessional team or interdisciplinary team here. And then the stepped arm, I think we were pretty clear that they could not be receiving home palliative care services. That was an exclusion criteria. And then I think that was an exclusion criteria in both arms, actually. We did not want them to already have seen home palliative care.
And that includes home hospice care.
Yes, definitely. And then we also didn't give them access to palliative care social work on the stepped arm. They had access to the cancer center resources, but they didn't have access to sort of regular contact with palliative care mental health professionals. Was that the same at MGH for?
We don't, our palliative care team here in the outpatient setting is only physicians and advanced practice providers. I would say generally, though, to answer your question, Eric, the palliative care content and clinicians were identical in both study arms. So those were intentionally not varied because then you're not just sort of comparing the cadence and the frequency, you're comparing different interventions. So, for example, the intervention visits had to be delivered by a physician or advanced practice provider.
So I got a question for you, Chris. You brought up a ICU study on it was titled had the word palliative care in the title.
I think our blog post, if we're talking about the same study, was like fast food palliative care, in and out palliative care, something like that.
In and out palliative care doesn't work.
It was nationally representative, so it was not in and out because I can't get those burgers here. It was just fast food generally. You're right.
So this study showed that doing in people with chronic critical illness, having palliative care lead 1.5 sessions in an ICU around prognosis and goals. I'm not even sure goals of care was a huge part of it. Didn't actually help, but actually worsened potentially some PTSD outcomes. And the entire community of palliative care said, it's not a palliative care study. Sure, it has palliative care in the title. Sure, there was a palliative care led prognosis meeting, but it was not a full interprofessional palliative care team. They didn't include all these palliative care, NCCN guidelines I always forget the
CQC.
Yeah. Not all the domains of palliative care were included. I wonder when you think about that trial versus this, which you can also make the argument that this was not a full palliative care consult team. How do you think about that?
Yeah,
I'm bringing it up since you brought up that trial.
I know. I'm happy to, and I'm gonna have to call the first author and tell them that I love them still because I still do. But the idea of do this thing, and we're going to call it palliative care versus do palliative care, and we're 9 years after that original article, right? The article, the fast food article, to use the parlance from the blog post. So I think we're in a different spot now. I think that article really helped me to realize if you're overly prescriptive about what a palliative care intervention is, it's less likely to work. Right? Mm-hmm. Palliative care is zigging and zagging and following the patient where they are. So being told you are an expert at this, we trust you, do palliative care. It makes it hard to report what's in the syringe, but it's putting the stuff in the syringe that the patient needs.
Yeah, I love that too, because I think that one for me really is, can our interventions need to target the patient population that we're managing? So in chronically critically ill patients, the idea that one visit is going to do anything is just, no. I think it was a great trial. I think we learned a lot from it, palliative care. I actually think it's a great palliative care trial. And I wonder, Jennifer, from this study, were there other things that, putting this together that was prescriptive, that these palliative care physicians, advanced practice nurse, that they were always going to do? Or was it, we're going to let you be, do your thing, but this is who the team members are going to be?
Yeah, so the team members were prescribed that at least intervention visits had to be physicians or advanced practice providers. As Pallavi said, you could refer to other providers. The intervention, I would say, was somewhere in the middle of scripted versus not scripted. I mean, the pro of scripted is, we have fidelity. We know exactly what happened. The con of scripted is exactly what Chris says. Like, you come in with an agenda. That's not what the patient's agenda is. So we trained all the palliative care clinicians on the model that we mostly deliver here at MGH, that early visits, when people who often look and feel like all of us, even though they're on chemotherapy or immunotherapy, it's about establishing a relationship and rapport. It's about instilling coping skills. And if they have symptoms, you address symptoms. And at some point, you might elicit goals and values. And at some point, you might talk about end of life care. But it's a very different model. It's an outpatient model where establishing relationships, as Chris said, getting to know what their grandchildren are doing, getting to know what they like to do, so that when the hard times come 3, 6, 12 months later, you have that trust and relationship to make those conversations happen easier, to facilitate them. What was very scripted was when palliative care visits occurred in STEP and how they occurred. So again, the STEP model is patient-centered. We monitored patients to know when they should step up to more frequent palliative care. And we did that with a quality of life measure. And that was very intentional. We did not just rely on a physical symptom measure, which many of our colleagues are doing. And the reason for that is the nature of our palliative care intervention. It's not just about physical symptom management. It's about coping support. It's about psychological support. And so we thought a quality of life measure, which incorporates physical well-being, functional well-being, emotional well-being, social well-being, and physical symptoms, was the right trigger to say someone needed more palliative care. Additionally, in case patients didn't step up, we did have sort of events where they were scheduled to see palliative care. So if their cancer treatment changed or they were admitted to the hospital, they were always triggered to have a palliative care visit, just because we know those tend to be very physically and emotionally taxing events in a cancer patient's life.
How soon after from a hospitalization?
All the palliative care visits were triggered. Generally, we gave palliative care because of the reason exactly what Chris said. Sometimes we can't get people in with palliative care. You sort of had a month after all of those events. So once the team saw that you had cancer, change in your cancer treatment, or admitted to the hospital, you were scheduled to see palliative care within a month of that event.
Did they also see inpatient palliative care?
Yes.
And that was that a trigger in the STEP group that everybody who got admitted saw inpatient palliative care?
So that's a great question. So in stepped palliative care, it was sort of up to the team. In the what Chris and Pallavi are calling intensive, I haven't called it that before, but I might steal it. Then inpatient visits were mandated.
Oh, truly intensive. Like, you're seeing
Really
everybody
intensive.
every 4 weeks. They get admitted. They're going to see inpatient palliative care. After admission, they also see palliative care. Like,
I know we're getting you confused. In the early integrated palliative care, it was every month and if hospitalized.
Yeah.
And then the STEP quality of life was monitored. If
Yeah.
their quality of life dropped, they stepped up. But for patients who weren't stepped up, after a change in cancer treatment or hospitalization, they would have palliative care visits.
And can I ask, Pallavi, maybe you know this. So you're doing these quality of life surveys. I'm trying to figure out how would this be implemented in outside of a research setting? How are the folks getting these quality of life surveys? How are you getting them back?
Great question.
Is this practical outside of a research setting?
It depends, which is not a great answer. But so it actually changed over the course of our study because, before COVID, everything was in person and we'd have these lovely research assistants and coordinators running around, sitting with patients while they did the surveys, getting them back in real time or hounding them to send them back by mail or email. And then we started pushing a lot more surveys electronically to patients, which of course has its challenges because not everyone's as tech savvy as our highly educated patients who have access to technology. So it even changed over the course of the study. Pragmatically, I think as more and more cancer centers and health systems move towards collection of PROs, I think it is going to be more feasible. But
PROs?
Patient-reported outcomes, I'm so sorry. Jargon. I think bigger cancer centers and health systems can probably implement these, but I think it's tough in a community-based practice to reliably collect these without boots on the ground.
Yeah. Chris, do you use them in your practice?
So it's an interesting question. We had something that was required of all patients. And the thing, if they didn't fill it out, they couldn't join the video visit. So people would be 3 minutes late because they'd be feverishly clicking these boxes. And we didn't ask for them, and we didn't read them, and we didn't look at them. So not what we're talking about within this trial, but there was a patient-reported outcome. I begged our tech people, I said, get rid of this. This is a barrier to getting the patients in the door. Now, if I had somebody who could catch these things, similar to what the research assistants are doing, or if I had a dashboard that Mr. Smith 3 months ago was this and now is this, that would be so useful to me. So I think that's the future, is being able to automate some stuff through the portal and then have a dashboard on the clinician side of, look at, these are the domains that the patient declined in between these two visits. Well, I'm not going to wait for them to bring it up. I'm going to bring it up in our next scheduled visit.
Yeah. Or if you have a team huddle, ooh, these ones are in the red. We need to...
We aspired within our group. Now we have 2 nurses for 8.5 FTEs. So we're like super tight in terms of our support staff. But we aspire to have like 10 patients or so that we call the hot list. So these are the patients who we're actively changing methadone. They've been in the hospital twice in the last 6 weeks. We want our nurses to keep up with those patients. But it's really hard to implement when the prior authorizations all need to get done.
Mm-hmm.
All right.
Yeah, it's real world.
So let's hear. I was going to say, did it work? But that's not the question, right, Jennifer?
That's not the question.
Was it?
Did it not work?
I'm not even going to say, was it equivalent? Because that's not the question either. Well, I just learned.
I feel comfortable saying it worked. And I'll tell you why. Because quality of life was non-inferior. So quality of life was, if we want to talk about it, just as good as the more intensive model. But we used significantly fewer palliative care resources. So basically, to achieve the same quality of life benefit as the intensive arm, patients saw palliative care significantly fewer times.
About half as less, right?
About half. Is that good English? I'm not sure. About half.
Yeah. Good enough for Jerry. That's GeriPal.
People understand, though. GeriPal grammar.
Yes, about half as much.
Right. And the quality of life included symptoms, right? Their symptoms weren't worse. Quality of life wasn't worse.
The quality of life tool includes sort of the 4 domains that I mentioned: physical, functional, emotional, and social well-being. And that it also has a lung cancer specific subscale. So it's the FACT measurement system. So there's like a FACT lung, a FACT brain, a FACT colon. And so they always have those 4 domains and then a cancer specific. So for example, the lung cancer specific one has questions about cough and shortness of breath, anorexia. So the quality of life measure encompasses all of those domains.
And the secondary analysis, no worsening in depression symptoms, or I guess equivalency as far as depression symptoms, use of coping strategies, prognosis, communication about serious illness or end-of-life care, just no difference between any of those outcomes.
No difference in any of our patient-reported outcomes. That is correct.
All right. I'm going to turn, this is the tough one. There was a difference, though, in hospice utilization. Right?
Correct. There was a difference in length of stay in hospice. So the length of stay in hospice in both study groups was longer than I think any other study that's ever been published. But officially, it was longer in the intensive arm than the step arm. And I have not asked Chris or Pallavi on their opinion as to why that is. So I'm very excited to hear their thoughts on why they think that was.
All right, Pallavi, I want to hear from you first. Why do you think? So I'm looking at the data right now, adjusted mean days, 20 days versus 35 days.
Which, hats off to the intensive arm. 35 days is amazing. And many, many times the national average, right? So my thoughts, and this is speculation on my part, but I do wonder if there was a slightly more sort of orderly transition to hospice on the intensive arm, because we had these social visits, these rapport building visits. We had a chance to address that sort of low level existential distress that I think we can pick up, that may not be picked up in the FACT-L, but may be picked up in sort of these very organic clinician-patient interactions. And so I wonder if and this is where I think qualitative data from bereaved caregivers would be super useful. On the lower touch arm, the stepped arm, was it a slightly more chaotic or sort of not as smooth transition to hospice.
Yeah.
Maybe it happened a little bit later because it just wasn't as smooth. And we hadn't had months and months of monthly visits to talk about it, the what ifs.
All right, Chris, my theory, and you can tell me if this is a dumb theory or not. My theory is that more people were seen by inpatient palliative care, and that's where a lot of hospice referrals happen for these individuals when they're really declining and they get discharged with hospice. So you're seeing, because everybody in the intensive care got inpatient palliative care, or they were supposed to, that's the reason. Stupid theory? Do we know of any data?
And I haven't seen, it's an interesting question. I don't know if we captured where the hospice referral came from. What my thought is, I like Pallavi's thought. My thought is probably driving alongside hers, which is that patients sometimes need to be told, I love you, I know you, it's time now.
Yeah.
For hospice. And if you wait for the hospitalization for the inpatient team to be the one to say that, you're going to get hospice, but you're going to get it for a shorter time because things have already decompensated. Where if we can do that in the office without the hospitalization, that's when people have longer times on hospice, is when it can be controlled.
So you're saying the exact opposite of mine. Jennifer, do we have any data to suggest which theory fits closer?
We are investigating it right now. I think one thing that's a bit tricky about it is just to be careful to not make inferences about subgroups, right? So we're looking at people who were sort of on the low touch versus who stepped up. And it gets a little confusing because you're slicing and dicing the population. The data on hospitalizations by study group, we are just starting to analyze right now. So you'll have to have us all come back in a couple months and we can tell you if there's a difference in hospitalizations and palliative care exposure. My guess is it's not that. I don't think that we're going to see differences in hospitalizations between groups or exposure so much to palliative care during hospitalizations. My guess is it's more what Pallavi was saying, that the sort of less intensive palliative care was able to do everything else except a super early referral to hospice. I don't want us to forget that 20 days in hospice is still something that is still pretty amazing. And so even though there was a difference, it's probably worth a discussion. Is that difference matter? Is that something we have to chase? Or can we say the length of stay in hospice or step palliative care was 20 days? That's amazing. And it's good enough. I don't know.
What do you think, Pallavi? Good enough?
Good enough in terms of the length of stay?
Like when you're thinking about this study, I'm trying to put this together in my mind. We have this study that shows less intensive palliative care compared to intensive palliative care actually was non-equivalent in pretty much everything we measured except length of stay in hospice. Like how much weight do I put in that hospice use secondary outcome?
I don't know that we know exactly the right dose of hospice to get max benefit. Like when do you plateau, right? We know that longer is usually better, but we're looking at short times being hours to days. So I don't know how clinically meaningful that week difference was to families. That's really who we're talking about, right? Who got the support they needed to take care of their dying loved one. Here's what I really want to know. I want to know, how are we going to better predict who's going to step up? That's what, and someone's got to say it this hour, AI, right? This 2024 is the year of AI. How can we predict who's going to step up so I can give those people that intensive care just, from the get-go? I don't know. I don't know we're going to know the answer to that, but that's really what I wanted to know after we looked at the results.
Yeah, speaking of like a practical approach, one thing that was mentioned in the discussion, I'm not sure if this was like the reviewers asked you to do this, is using prognosis as a trigger. And, we're kind of like, we do e-prognosis, we do a lot of prognosis stuff. And I completely agree, like quality of life should be the trigger. Like a decrement in quality of life is the ideal trigger, not prognosis, not a shorter prognosis. And it's a lot easier to calculate prognosis likely from, the labs and the medical record than it is to like get patients to respond onto a survey about quality of life. So there's some trade-offs there. I don't know if any of you have thoughts about that.
Or are both important? Like quality of life is really important, but also like when somebody's prognosis suddenly changes for the much worse, shouldn't that be a trigger as well?
Yeah, I mean, I think if I think about the next step, which is actually what I'm going to call the next study. Isn't that cute? Next step. I think exactly what you are saying is what we need to do. We sort of need to combine stepped care with AI prognostic models. Pallavi knows this. I'm not sure if Chris knows it as well, but we have, and if anyone is on the study section is listening to this, you are meeting next week. So hopefully this will convince you. We have a proposal that's been to NIH several times using an AI prognostic model to identify palliative care needs. And it has been trashed multiple times for a wide variety. I know this is so inappropriate, but I'm just going with it now. Maybe there are viewers listening because of concerns about the ethics of using AI to identify palliative care needs.
Huh.
What's the concern there? Because we're using AI to do everything right now, it feels like.
We sure are, reviewer. We sure are. I feel like Kamala Harris, about Trump. Next question, right? It's right? And what's the risk of someone seeing palliative care earlier than they were quote unquote supposed to?
Right.
I don't know, but I'm hoping the third tries a charm, but I make promises.
I have another question about, relating to your prior study, like the landmark reason, let's just call it, speaking of, can we say it on this podcast, AI, the NEJM paper on early palliative care, the big reason it made headlines wasn't the improvement in quality of life, which was great. It was the lengthened survival, in the patients randomized to early palliative care. Now, I notice survival wasn't a component of this study. I wonder what the reasons for that are. And might it be that my hypothesis is that those, small gains that might be seen in a palliative care arm in terms of survival are dwarfed by the gigantic differences that we've seen in the intervening 10 years in, cancer-directed therapy.
Yeah, that's exactly right. You really could not look at survival in an unselected metastatic lung cancer population in this, 5 to almost 10-year period now. There are just too many sort of predictive and prognostic factors that we would not be able to control for. So that is exactly correct. But it goes to how you kicked off this podcast. We don't need a usual care arm anymore, and we don't need to show the value and benefits of early palliative care. It has been shown. Done. Close that chapter.
Well, wait,
can I just ask, what was the survival
cancer
in this group? Do we know how long people lived?
We made a very thoughtful decision to not look at it, because if we do, people are going to ask for the differences between study groups, and that is a flawed analysis. And I don't think we should be looking at data that we don't feel like we have the rigor to make inferences about. So we are not looking at it.
You're saying it's a flawed analysis because, as what you said earlier, there's so many components, what goes into survival for these different groups, that it would be hard to make comparisons that were fair. You couldn't adjust for all of those factors because you didn't collect them or you don't have access to them or whatever.
Correct.
Yeah.
Sorry, Alex, you were going to say something?
No, I was just going to say that case is shut, that palliative care should be usual care in advanced lung cancer, and that, for non-cancer illnesses, for other conditions, there still are questions where usual care might be appropriate. Is that fair to say? I'm workshopping what I'm going to say at the Congrès du
Palliative.
Thank you.
You're welcome.
Yeah, I think Alex is a great point. So we have this for lung cancer. Do we need to repeat all of this for different kind of cancers? Is it really open and shut for other conditions, or do we need randomized controlled trial for different conditions, different stages of conditions? What do you think, Pallavi?
I sure hope not.
Chris, no?
I sure hope not. Because if you, if we go back and you think about palliative care as cross-cutting, right? Yeah. And if we go back to every single underlying condition that we can help with, and if we've got to build that house from the dirt, we're going to be talking about this in 2086.
Well, we have to, because every 10 years we're going to have to update it too to keep up.
We still haven't gotten to Huntington's disease, but we'll get there by 2116, right? Like at some point we have to say we don't hurt people. We know that. The question of, as a limited resource, who are the right people for us to help? That's in my mind, probably still open.
Yeah.
But I think when we have an opening like an ASCO guideline, we should drive the truck through there. And then I love the idea that really this trial was about is how much is enough? Because if we give somebody a lot, that means, at least at my institution, some other people are not going to get any.
Mm-hmm.
So I want to be mindful of the time. I want to ask kind of what's next? What do we do with this? And I wonder from each of you, I'm going to start off with you, Chris, kind of what is next? What do you think the next thing we should either do in your own clinics with this data, or maybe from a research perspective? You can take either one of those.
Yeah. And as the non-researcher in the group, if I could kind of hang the stars around this, what I would do is build some patient-reported outcomes that allow me to know my patients who I see on kind of the routine refill every 10 weeks, every 12 weeks, who is suffering in that group and I don't know, so that I can pull them in an earlier slot.
That's see like a dashboard to see how they're doing.
Exactly.
So similar to this study, except kind of automated, no research assistance needed. And then you're looking at that dashboard.
I would love to build that. Yeah.
Pallavi?
I think I would like to see us operationalize these critical clinical points and use them as triggers for sort of kind of an automated palliative care consultation. So if a patient with advanced lung cancer needs palliative radiation, a change in therapy, or an unplanned hospitalization, to me is actually the number one sentinel event. That always alarms me. I feel personally ashamed when my patients get admitted to the hospital. So when that happens, I think that should trigger sort of reconnecting with palliative care. So I think that's actually fairly easy to operationalize and shouldn't require a great deal of manpower. I think the quality of life assessment was really brilliant in this trial. And on my wish list would be a way to operationalize it that doesn't add to clicks or headaches or, make clinicians want to pull their hair out. But I do think that's really important. And then my third sort of wish is that if we were operating in a stepped care model, is giving folks access to people like palliative care social work, because we know so much of what's in the syringe is coping support and that rapport building. We have found that when we partner with our palliative care social worker, even if we're trading visits, patients feel cared for, and they don't have to have a financially toxic visit every time. They can do a virtual visit with a social worker and still feel connected to the team. So those are three things I'd love to implement today.
And Jennifer, next steps?
I would like us to continue to maximize palliative and supportive care for patients with newly diagnosed advanced cancer and use fewer palliative care resources. So my next step is to try to integrate digital apps and videos and other things that deliver palliative and supportive care.
AI palliative care versus human palliative care.
There you go. That's it. That's the end of the podcast.
Very fitting.
Well, we could talk much more about everything. I just want to thank all three of you. But before we end, Alex, I think a little bit more, is it Galileo?
How long till my soul gets it right? Can any human being ever reach the highest light, except for the resting soul of Galileo, king of night vision, king of insight?
Alex Smith, Indigo guy, everybody.
Pallavi, Chris, Jennifer, thank you for being on this podcast. That was wonderful. I had a wonderful study. We'll have links to the study and to some of the other things we talked about, like the ICU study, in our show notes today. Thank you all.
Thank you.
Thank you. Bye.
And thank you to all of our listeners for your continued support. We'd also like to say a very big thank you to the donors who've donated more than $250 in the last year to support the GeriPal podcast, including
Asher Edwards, Jerry Gerwitz, Victoria Brond, Meg Walhagen and William Strawbridge, Jessica McFarland, James Tulsky, Susan Nelson, Sharon Brangman, Daryl Owens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Strait, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, and Stuart Oserman.
Thank you very much.